go over the hit on a couple of points on this paper. So if you've got that handy, I should have told you to go ahead and pull it up. So I wanted to point out a couple of things with regard to this paper. In particular, that you guys, it sort of will reemphasize what I had talked about earlier. And so the first thing I want to go to is the absorption on this paper, which is on the very first page. And I just want to hit a couple of highlights in a couple of these sections because I think they're important. And so basically, what Davies and Nutt talk about is the aspect of the rate of absorption. And one of the things he puts on is that when we're looking at absorption, that is basically us trying to get the drug into the bloodstream. And so the absorption will vary between drugs. So one of the things that he points out is that one thing is we talked about first pass metabolism. So one thing about changing route of administration, we can sometimes get around first pass metabolism. So for example, drugs that are administered intramuscularly will not go through first pass metabolism because they will be absorbed into the bloodstream directly and won't go through the portal circulation initially. So one thing that when it comes to absorption, and it deals with also administration, that we can many times overcome some of these issues. For example, buccal administration, nitroglycerin is a drug that can be given under the tongue, and we do have a few other drugs that may be psychotropic or that act in the CNS that can sometimes be given under the tongue and or buccally, and that gets around first pass metabolism. So that's an important thing to be thinking about. The other thing is that when we are looking at the absorption issues, one concern that we will have is, for example, the wherever we administer the drug, the blood flow to that area. So when we give it orally, the blood flow to the GI system is going to be very important. But when we give it intramuscularly or subcutaneously, things that affect blood flow to those areas like heat and things like that can change the rate of absorption. The other thing that we find is that these depot injections where we've seen these used for, like, for example, haloperidol. We also have some, I think, risperidol. These allow us to give a sustained release. We did have some birth control pills or birth control preparations that we gave, and we still do, where you use a depot, and that that can allow for a prolonged administration. Same thing as that we mentioned yesterday is when we talk about drugs like that are controlled release or XL or XR, those type of things, they will form like a depot, or I should say they're slowly released, and so that may allow for an extended action. These type of things we use specifically for individuals that compliance may be an issue with. The other thing is we talked about distribution. I'm moving to the second page, and he went into a little bit more detail than I did, but one of the things he talks about is there is the redistribution and the elimination phase. So one of the things when you're frequently given half-life of a drug, what they're giving you is actually the elimination phase. They sometimes will describe it as the elimination half-life. And one of the things that I wanted to mention is when you look at the literature, sometimes drugs that have long half-lives, sometimes the parent drug has a long half-life, and then you may have active metabolites and they have a long half-life. And sometimes what you may see is the literature may give you a half-life that seems longer than some other sources that you get. And that can sometimes occur when they combine the half-life of the active metabolite and the parent compound. So just be aware of that. This paper does give you a good sort of summary of the substrates. So that's a good reference for you to have. Obviously, since this paper is a little old, it doesn't contain everything, but it does give you a good group of drugs. And I was trying to think, I wanted to mention two other things. And this is on page 272. So area under the curve I mentioned, and so he gives a pretty good description under here. This the area under the curve actually represents the total amount of drug that's present in the body over time. So we use that area of under the curve to do some other calculations, but it is the area under the curve can change depending on how fast or how slow a drug is metabolized or excreted. So what we see sometimes is the area of the curve is large in individuals that may be slow metabolizers. But the last thing I really wanted to point out in his article is I've talked about bioavailability, okay? So bioavailability, sometimes it's abbreviated as F, F as in Frank, which stands for fraction. And so what bioavailability really is, it is the percentage or the fraction of the administrated drug which actually reaches the systemic blood. Okay, so for example, if I give a IV injection, then the bioavailability is 100% because I'm actually injecting the drug directly into the bloodstream. Okay. What we find is drugs that undergo first pass metabolism, their bioavailability is low because before they get to the systemic circulation, they go through the portal circulation and are metabolized. And so first pass metabolism decreases it. So how do we determine bioavailability? So what we do is we give an IV administration of a drug, and then we can measure the plasma level. And then we give, after a washout period, then what we do is we give the individual, if the drug's going to be administered orally, then we give it orally, and then we measure and determine what the level is. And so by taking the fraction of the oral administration versus the ratio of the oral versus the IV administration, that's how we calculate bioavailability. Okay. And so he uses it here as basically they actually use the area under the curve. So they do the plot out and they draw the, basically sample, as I told you they would do with a pharmacokinetic appearance. They get the area under the curve and after IV, and then you get the area under the curve after oral or intramuscular or whichever way you're going to give. Typically, most drugs that are given orally are not going to, they're going to lose some. I mean, you're not going to get usually 100%, simply because a little bit of it may be lost in the stomach or be tied up in the feces or bowel or something like that. So typically the bioavailability for intravenous drugs is 100%. Every other drug and route of administration is basically going to be a percentage of that. And like I said, there are instances where that basically the bioavailability, some of the drugs that you guys will administer, and this is in the package insert, will be maybe 40, 50, 60%. Sometimes it's 90%. So for example, what that means is if I have a bioavailability of 90, if I give 10 milligrams, that means 9 milligrams will be absorbed, and 10 milligrams, roughly 1 milligram, is not going to be absorbed or get into the bloodstream. Okay, so again, that's a good sort of concise, very important points or pertinent points with pharmacokinetics that I think is good for you guys. So does anybody have any question about what we covered this morning or about the paper? All right, so the question is, are there any implications for administration of lipophilic drugs to people with very low body fat percentages? Typically in the drug range that we're giving, or most drugs, is that would be negligible. We do know that sometimes the lipophilic drugs may accumulate and stay around a little bit more, but if they're in the fat, if most of it will be in the fat, then it's not really going to be a large dose that's going to be out in the active tissues, for example, up in the brain. So typically it's not. A lot of times, bigger people, when we see a difference, it may simply be that their liver is larger, and bigger people may sometimes, alcohol is a good example, is women usually are affected affected at lower are affected more quickly than men. And one of the reasons is women tend to have more body fat, subcutaneous body fat, and they have less body water, and the alcohol gets distributed in the body water. And so there, in a male, you have more body water to distribute it in. And so there is a difference there. But for most drugs, it's going to be negligible. You may see the drug hang around for a while, and you may have some potential for accumulation. But again, if it's in the body fat, we're not as worried about it because we're assuming that it's not going to be released heavily. We see, like, for example, marijuana may stay around for a while, and the body fat may be like a slow depot releasing. But that's for most drugs, just the difference in body fat is not going to be a big issue. Okay. All right. So this next group of slides are this is actually an educational module that myself and several others developed several years ago. I don't know if you guys remember, but Pfizer got fined fairly huge amount of money for mispromoting. What they were doing is they were promoting some of their drugs. I think it was gabapentin for indications that it wasn't that it hadn't been approved for. So as a result, they got levied with a pretty heavy fine. And what the attorney generals did, which was I thought was a pretty smart thing. Of course, I'm a little biased because I benefited from it. Was they put out some grants that you could apply for, and they were competitive. And they took the money and used it to try to educate healthcare professionals. So we, myself and 3 or 4 of the people at the college, I put the grant in, and basically we proposed 2 things with the grant. One was to develop some educational modules to provide to practitioners, and our second part of the grant was to put the modules out and see if it would change prescribing behaviors. The mechanism by which we were going to change prescribing behaviors was sort of interesting. I don't know if you guys know this, but when you start writing prescriptions, that is tracked. Were y'all familiar with that? That physicians' prescription writing is tracked? Okay, a lot of physicians aren't aware of that. I mean, we know that, with recent things, we do know that the opioids and scheduled drugs are tracked, but the other prescriptions, and in fact, there's a company called IMS, which basically drug companies pay huge amounts of money to get this type of information. And so one of the things, and so it's not just control, it's not only control meds. So in fact, what drug companies can do is they can actually purchase databases, and they can find out, basically who's a big prescriber of this drug, who's a low prescriber of that. And so this doesn't go to a regulatory body. This doesn't go to anybody that's tracking you to say, for example, you're writing too many ADHD meds or things like that. This is like people that are writing antibiotics and so forth. So a drug company can pay for money to find out, they can find out who are heavy prescribers, who are light prescribers, who are prescribing their competitors. So all of that information is available at a pretty hefty price, but it is available. So what we were going to do is we were going to use sort of the database, and we were going to take a group of prescribers, we're going to educate them, and then see how their prescribing changed. And we were going to do this. We weren't sure we'd be able to pick up anything on such a short time frame we were dealing with, but nevertheless, the issue became that IMS was we were not a big payer, and so one of the things that we ran into was basically we were sort of on the back burner, and so we had to drop that part of the project. But we did get these educational modules that were developed, which we then sent out to various organizations for them to use for CE. So this one was actually modified, and I wrote it primarily for psychologists. So that sort of give you a background of this, of where these slides came from. So important information, which one of the other things that was discovered is that physicians, in particular medical students, were not getting a lot of information with regard to drug approval and things like that. So there was definitely identified a need for trying to increase that. So I had already incorporated a lot of this. In fact, even before the grant, I was teaching this with Alliance students. I was teaching this with Farley Dickinson students. I was teaching several of these slides type things to my own students. So we're going to skip by the objectives. So so what I did with the one we're going to look at today primarily was I focused more on the psychotropic drugs. Okay. So here's some unique problems or special problems that you guys are going to run into. All right. So number one is with psychotropic drugs, we find that many of these drugs are used off-label. Okay. Now, off-label, we'll have another slide on this a little bit later, but I think most of you know generally what off-label is. When a drug goes through approval, a drug company specifically has to provide an indication or indications for approval. So it could be that they put it forward to be approved as a antidepressant, let's say. Okay. Now, the other thing is that they may put it that it's for adults, so 12 and older or 18 and older. And so anytime that you use a dosage or for a different indication, basically that's being used off-label. Let me give you an example. Imipramine. Imipramine is a tricyclic antidepressant. It was actually approved for originally for treatment for depression in adults. Originally, it was not approved for enuresis, bedwetting. All right. So in children, imipramine is approved for enuresis, but it's not approved, or it wasn't. I don't know if it is now. I don't think it is. It wasn't approved to be used as an antidepressant in children. So if you were treating a child, if you had a child and you were going to treat the child for bedwetting, then basically that would be used on label. But if you were treating that child for depression, that would be an off-label use. Off-label also would be if the drug was approved for use, let's say in dosages between 10 and 50 milligrams daily. So if you went above the 50 milligrams daily or below the 10 milligrams daily, that would be off-label. So off-label is the FDA does not, their statement is we don't practice medicine. And so their statement is basically physicians and prescribers are welcome, or if they feel like that they have a rationale for using it, the FDA does not prohibit off-label use. The FDA does prohibit drug companies from marketing it as off-label use. Okay. So many times the label basically says safety and efficacy has not been determined for example, if it's a drug approved for adults, it may say safety and efficacy has not been established or determined for children 18 and under. And so it doesn't mean it's necessarily not safe or not efficacious. It just means that the FDA has not been able to evaluate it, or was not given the opportunity to evaluate it, or it was not submitted for that. Okay. The other thing is you have a lot of different special populations. Okay. The populations that you're dealing with are basically, these can be, you're dealing with children that may have special issues, autism, different things like that, some elderly patients. So there's different populations that you may deal with that would be considered special populations in which the drug may not have been approved for. All right. Or even if it's been approved for, these populations a lot of times by nature are a small group. So it's not like it encompasses a huge number of patients that are used for. A lot of times is we have comorbid psychological diseases and other diseases. Many of you, just out of curiosity, if I were to ask you what is the average number of comorbid diseases that you would see in your population, in the patients you're seeing, how many do you see? So any diagnosis. So a lot of them, I mean, most of your patients are going to see see a lot of different conditions there. And when we talk about comorbid, sometimes it could be metabolically compromised, right? So Kristen, that would fit there too. But one of the things you see is that, you know, if you're dealing with older patients, you're going to probably have, it wouldn't be surprised if you have diabetes, high blood pressure, cholesterol. With younger patients, you know, we don't think about these sometimes as comorbid, but you may have, you know, juvenile arthritis, you may have diabetes. We may have kids that have ongoing infections, respiratory, COPD, asthma, those type of things. So when you throw in those other mixes, so when these drugs are being approved, Rebecca, that's another one, obesity. Many people don't think of that as disease, but that can have serious health consequences. Delayed, for example, some of you dealing with children, one of the things that you may be dealing with is some of them may have delayed growth. Janelle, a lot of patients may end up with hepatitis and STDs and things like that. So these are all things that has to be, you know, that factors in because they're going to be taking drugs for that, or the pathology may have a direct action. So for example, people with recurrent urinary tract infections can develop some renal problems. Okay. So that's that's another thing. Another thing is, you know, if I go to the doctor because I have a sore throat, I'm pretty much going to feel like after about a dose or 2 doses of my antibiotic, my throat's going to start feeling better. In fact, one of the concerns that we have is like people that come in with respiratory infections or things like that is they're not going to take all their drugs. They take 2 or 3 days. That's why we go to the Z-Pak a lot of times, is because we know we can probably get them to hopefully take their drugs for, 5 days, but that's not always the case. So you are dealing with individuals that may have, think about depression. It may be 1 to 3 weeks before you see any at the beginning of a response, and probably 4 to 6 weeks. And here you have somebody that's in depression, and you want, the parents are wanting the child to be gotten better quickly. People that have anxiety and so forth, they want the immediate response. We have a delayed therapeutic response. And one of the things that is difficult is sometimes physicians, what they start doing is if the person hasn't shown some improvement with regard to, let's say, a depressed patient, if they've not shown improvement in 2 or 3 days, they're changing meds, adding meds, or possibly up in the dose. So I don't know. Arnold, I'll just simply tell you is there's a couple other people that have had difficulties logging in this afternoon. I do not know why, but just pass that on to you. The other thing is that blood levels don't correlate with therapeutic response. What I mean by that is that if we were to measure blood levels of someone taking, let's say, Zoloft, then the blood level, what we might find is what is called a therapeutic range, which is what we would expect to see in somebody that's taking Zoloft and is getting an effect. But we can't correlate that to an effect. What we can see is that we might be able to see whether they're in the therapeutic range or below therapeutic range or above the therapeutic range. What does that tell us? No real correlation with effect other than if they're below therapeutic range, we may not be getting an effect. If they're above therapeutic range and we're seeing side effects, it may be they're taking too much. The other thing is proper diagnosis, and the one that comes to mind the most is depression versus bipolar. So here's the thing: when somebody is bipolar, do they show up for treatment because of the mania or the depression? Correct. They're going to show up for depression. So they show up at their general practitioner with depression. So what happens is they basically treat them for depression. Okay. Now, treating them for depression and not for bipolar, one of the problems that you can run into is that if you choose the wrong medicine and you're treating them for the depression, you may actually merge them in or move them into mania. Okay. So that is a big issue. And what was interesting, that's a good example, Janelle, is that you get some of these activating agents like Effexor, and you're treating somebody for the depression. And a lot of people like the Effexor because they think it kicks in a little bit because it's more of a stimulant action. And so the next thing you've got them going to mania. And so what was interesting is, was it Seroquel that the ads were, I think it was Seroquel that they were advertising for treatment of bipolar. And Janelle, I don't know if anybody's had experience with that, is the Wellbutrin. I have seen some people that it has moved them to mania. So it's one of those things that you've got to be careful with. I've seen some people that have been treated with Wellbutrin and seem to do well, but I have seen especially some adolescent teenagers, that's sort of a duplicity there, but I've seen some teens that have been bipolar that have been put on Wellbutrin and moved more towards the mania aspect. When I think it was Seroquel came out and they were advertising for depression, we saw a lot of GPs start switching people over that were depressed to Seroquel. And so it's very important with proper diagnosis. The other thing is that with proper diagnosis, we have clinicians that still feel that the way they determine whether a person has ADHD is they give them ADHD meds to see if it improves their concentration and focus. And if it does, then they say, therefore, they must have ADHD. So that is another thing there. So proper diagnosis, if improper diagnosis can create a lot of problems. The drug side effects can sometimes mimic the disease. So sometimes these drugs, even though they're, somebody may have symptoms of depression, and what may happen is some of the drugs may sedate people and make them think they're even more depressed. Some of the anti-anxiety medications may actually be activating. Picking the wrong drug can sometimes be that. And then one of the things that you run into is with these drug side effects is that patients may make them up in order to either avoid taking a drug or getting a drug. We see parents sometimes do not want their children on certain ADHD medications. So what they do is they come in and tell the clinician, they're not even giving the kids the medicine, but they will tell their clinician, oh, no, he's having this, or this, and so they want to take him off it. So we do see these drug side effects that can mimic the disease. Sometimes when a patient comes in and you're prescribing an older drug, but they want something that maybe a name brand that their neighbor is using or a friend of theirs is using and says it's working great, even though they may have a slightly different diagnosis than their friend. So what they do is they may make up side effects to try to talk you into switching them over to what their friend or what they've looked up on the internet. Don't know if you guys have run into that, but that's another thing there. And then a big thing is patient compliance. Patient compliance is patients, if they don't want to be on the drug, they just won't take it. We see sometimes patients may not know how to take the drug, or they change the way the drug is being taken. Older people sometimes will take drugs, because of the cost. They may sometimes take the drug every other day. In fact, I don't know if you guys saw it on, maybe I mentioned to it, I don't remember, on the show New Amsterdam that was on last week. There was a kid that had a heart transplant. And basically his parents couldn't afford the meds, so they had been giving him the immunosuppressant every third day to make it stretch out. And so it is one of those things that creates some real problems, and whether the patient tells you they're taking the drug. One of the things that patients sometimes will do is they'll try to get a faster response, so they may start taking more of the drug at the very beginning. So that's another thing is patient compliance. Patients don't necessarily want to tell you or want to admit that they have, that they're not taking the drug as prescribed. One of the things that's very important is that when you're prescribing these drugs is you go over with the patient, and that's an issue. And so you sit down and basically say you need to take this, tell them whether they need to take it with food or something like that, telling them whether they need to not take it with food. That also, when they first start taking the drug, they may have things like orthostatic hypotension or things like that. And if they do get side effects, the other thing that we need to do, running into a problem like this, is to let you know, because sometimes it can be a dosage, or sometimes it may just simply be there are some little tricks that you or the pharmacist may be able to tell them. And as we go through the psychotropic meds, I'm going to give you some examples of some of those things that we find that may be helpful. Sometimes it's a situation where the patient, it's not life-threatening, but it's just bothersome enough that the patient won't take it or doesn't take it on a regular basis. But you're trying to judge where the response is going. So you're under the impression that the patient is taking the drug, whereas the patient isn't. So you may increase the dosage or change to a different drug, thinking that the drug that's been prescribed is not working or is not as effective. So these are things that need to come out. Patients will take a prescription from you. They may not go get it filled. And so one of the things that you just simply need to do is you need to ask whether they're taking it. Also, every time you see them, is make sure there's no change in other medications. Or we will see a lot of people that will find stuff on the internet that comes across as safe and natural. And so there's the tendency for them to buy that. So things psychotropic over the counter, just a couple of things, which I think most of you are aware of, is SAMe. You guys know what SAMe is, don't you? Yeah, I think most of you. So it's like this. It's S-adenosylmethionine. And the theory between using SAMe is that the adenylmethionine is used to make transmitters. So the aspect is the thing is the patients think that it's going to make more transmitters, and that helps. And that can work. Kirsten, that is a great idea that happens. And I will tell you something we do here is sometimes our pharmacist or our medical residents will go to what we call brown bag lunches. And so a lot of times they may go to like a assisted care living home, or sometimes a church, and they have the people bring their medicines in. And so the person sits down. So the residents or the pharmacy students will go over what each medicine does and talk to them about taking it and what to look out for. And that works really, really well. And that works good in one of the things we found is sometimes African Americans are very suspicious of healthcare because of the Tuskegee experiment. And what we found is by going through the churches, and some of the African American women have been really good about getting some of our healthcare people into populations that don't really trust physicians in general or the healthcare system. And so that works out pretty well. But a lot of it, even when you're prescribing it, is make sure the patient is, or the caregiver understands exactly what you're doing. And you can also have them, the pharmacist can also reiterate that. We try to make sure our pharmacists do ask that, but sometimes the pharmacist or the pharmacist tech just simply says, do you have any questions? And at that time, most of the people don't know. So making sure that your patient's being compliant is important, as well as if they're not being compliant, try to find out why. Sometimes there's things that show up on the news that just scares them. And so what happens is that they just don't want to take these drugs. All right. So what we do know is, as I told you the other day, is when you're doing risk benefit, I mean, every time you prescribe a drug, every time you're going to change medication, whether it's changing a dose, taking a drug away, you should be doing a risk benefit. Okay. Now, every drug, I've got any drug, every drug, every, whichever one you want to use it. Every drug, every substance carries a risk. That includes prescription medications. That includes over-the-counter medications. That includes herbals. And when I say herbals, I'm going to include homeopathic medicine there. It includes supplements. So all of those things have a risk when you take them. In fact, a colleague of mine years ago, he would say, if it's harmless, it's useless. And so one of the things that we have to realize is that that is an issue. So let me go back, because I used the term SAMI. So SAMI is basically, sometimes they will see that over the counter and they'll say that it helps with depression. And so the idea is that when you take SAMI, it gives you more adenosyl methionine. So theoretically, your body takes that and is able to make more transmitters. So that's the way it gets rid of the depression. And so because theoretically you're making more serotonin, but that's, in theory, is correct. In practice, we don't necessarily know, what concentration of SAMI is there, whether it's even getting there. So, but the patient may take that in addition to taking, one of your drugs that you prescribe. And a lot of these supplements, we don't have all the drug food interactions, or I should say drug supplement interactions. Also, some of these medications have been found to have undeclared substances, which means that they may have, for example, they could have Zoloft in them. We found that a lot of the drugs that supposedly are improving fertility and are used for erectile dysfunction, some of those actually, the reason they were working is because they had Viagra in them or Cialis in them. And so they weren't supposed to. But what happens is if the FDA finds out about it, then they tell the drug company they have to pull it off the market. So sometimes that occurs. So Eddie, you ask a very important point. Question, is homeopathic basically inert? Not necessarily. Here's the example I give. And if you guys have heard it before, then just forgive me. I just saw something during the break that said people that are forgetful and, can't remember things all the time, it's just a sign of high intelligence. So I figure it's either I must be a highly intelligent old man that sort of covers everything. So this is the thing, is that let's use water. Water is inert. Theoretically, people would say it's inert. So somebody asked me in a trial that one time, they said, Dr. Tackett, are you saying everything has side effects? And I said, yes. And, they went through this whole thing about, basically, that I'm under oath and blah, 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 and so forth. And then she re-asked me again. She says, so you are insisting, and your testimony is that everything has side effects? And I said, yes, ma'am. And she said, what about water? And I said, have you ever heard of drowning? That's like an overdose of water. But so even water can have a side effect. Okay. In fact, we have water toxicity. I think some of you may remember that there was a radio station that had a contest a few years ago where a woman, they were seeing how many could drink the most amount of water, and the woman actually had seizures. She developed water toxicity, which means she drank so much water, it diluted out her sodium and she went into seizures. And I think she died, if I'm not mistaken. I think the radio station got sued pretty heavily for that. But the thing about it is that any of these substances, if you think about it this way, if it's homeopathic, the idea is that if it's inert or it's not working, then why do you need it? So if it's, we do see a lot of things that in the doses or whatever they prescribe don't have any effect, but in some individuals they can. So there is a potential for every substance to be toxic. Keep in mind too, prescription drugs and over-the-counter drugs all go through a approval process. The other drugs, the supplements, the homeopathic medicines and so forth, and foods, basically a lot of those things the FDA oversees, but they're not required to do the safety and provide all the safety information and everything that's necessary that we see for a prescription or an over-the-counter drug. So when we're talking about drug development, now what we're going to talk about is basically once a drug substance is deemed that we want to develop it as a drug, what has to happen for it to get through the FDA and get approved and so forth. Okay, so what you need to know, basic information, is that when a substance is going to be put forward to be approved as a prescription drug or even an over-the-counter drug, is the process that the FDA goes through is an initial basic assessment of efficacy, which means does the drug work, and safety. Can it be used safely? It wasn't too awful long ago that drugs did not have to be proven to be efficacious. Okay? I mean, the drug companies basically just didn't have to prove that it works, but that has changed. Okay? So the FDA expects the drug company to provide them with the information that demonstrates that their drug is going to be, that it's going to work and that it can be used safely. Okay? The FDA, along with that drug, the drug company has to write and provide a label. Now, the FDA gives a template of what has to be in that label. We'll talk a little bit about that a little bit later on today. But basically, the FDA approves the label. So the drug company submits the label. The drug company is responsible for writing the label. They submit it to the FDA. The FDA says, this is correct, this is not correct. We don't agree with this. Give us more information or whatever. But that label, which is the package insert, that, as I said earlier today, should provide the important safety or important prescribing information for clinicians. Okay? So this process, by understanding it, gives you you can see where the information is coming from and how the information is evolved, so that the information that you get, you know how to use it. Okay? So that's what we're looking for. And we're going to go through that process. So let's see. This would be a good time to take our first break. So let's come back at 10 after the hour, and then we're going to start talking about the drug development process. And we'll start with this. This actually came from the FDA, and this is what they give. There's a lot more information on here than what we're going to go over. But anyway, let's come back at 10 after the hour, and we will start talking about what happens with a drug molecule once it starts and how it gets approved. Okay? All right, so I'll see you guys at 10 after the hour. Okay, guys, let's go ahead and get started here and move on. So this is the outline of the drug development process. This is actually put out by the FDA. And let me just show you. So a couple of key points here. And so number one is, let's see, we'll go with red there. Maybe that, no, I don't want that. Okay, so what we have is we have the preclinical research. So this is actually what's done in the animals. This is the in vitro work. This is animal studies. These are all done. This involves the actually synthesis and purification of the drug. And so we're going to do animal testing primarily, and the animal testing, which we've cut back with quite a bit compared to years ago, because now we have some in vitro tests that are just as predictable. So what's going to, in a nutshell, is this preclinical research. The company is going to put it together. They're going to do all of this. And what's going to then happen is once they gather this data, they are going to then submit what is called an IND. That's an investigational new drug. The FDA will evaluate these animal studies and this in vitro work and so forth, and the chemistry involved in synthesizing it, and basically they will make a decision pretty much from a standpoint of whether there's enough data which suggests it's safe to move into humans. They may come back and say the drug is dangerous. We don't think it's going to, we're not going to approve it. And a lot of times the drug just drops off there. It doesn't go any further. They may say we're going to approve it, but we want some additional animal studies. And then what's going to happen is, let's say it's approved. Then the drug company can then move into human studies. And so what we find with the clinical studies is basically there's 3 studies. We're going to go into those in a minute. Phase 1 is pretty much where that the individual is going to, the drug is going to be tested in normal human beings. Phase 2 is the first time that it will go into the patients that have the disease for which the drug is intended. And then phase 3 is where these are the large random controlled clinical trials. And then if those are successful, then what's going to happen is the drug company is going to then put everything together, and they're going to submit an NDA. What the NDA basically stands for New Drug Application, and that NDA includes all of the clinical studies, all the preclinical research, and then the FDA will decide whether the company can market it, whether the company's going to, the FDA can disapprove it, and sometimes the FDA can approve it and then say we want some additional post-marketing studies done. So that's this in a nutshell. So let's explore this in a little bit more detail, okay? So preclinical testing, what's going to happen is we're doing in vitro and in vivo animal testing. We have a lot more cells and in vitro testing, which is predictable. We can take in vitro testing and we can do a receptor profile, determine what receptors the drug will act on. We can determine a lot from in vitro testing, and so that has cut back a lot of our animal testing compared to what we used to do. So in this preclinical testing, what we're hoping to do is to characterize the drug from a standpoint of we really want to be able to describe its pharmacology and toxicology. So we're going to give doses that far exceed what we would anticipate ever seeing in humans. We're going to look at multiple species. Typically, you're going to see the studies done in mice and rats. Rabbits is a subject, guinea pigs, dogs. We do very little primate research anymore, but most of this, and typically we're going to have to demonstrate the safety and basically pharmacology and toxicology, typically in a rodent species and a non-rodent species. We're also going to do the initial pharmacokinetics. We usually do that in rats and probably dogs. We have to recognize that rats and dogs, or any animal, may metabolize the drug slightly different than in humans. So we do have to recognize that there are differences there, but it will give us an initial assessment of the absorption, distribution, metabolism, and excretion of the drug. We're going to several of these animals are going to be sacrificed at the end of the experiment. We're going to do a lot of pathology on these animals. We're going to test for carcinogenicity. So is the drug cancer? Can it produce cancer? Typically, to do the preclinical testing, it's estimated it takes anywhere from 3 to 7 years. So a pretty extensive testing there. So then if the animal, once those animal studies are packaged, and throughout the testing, the company can have discussions with the FDA, and the FDA can give them some guidance. For example, okay, we're looking at this and we're going to need to see studies that specifically address maybe this or this or this. So once the animal studies, a majority of those have been completed, this is put into an IND application, investigational new drug, and that is requested, send it to the FDA. And that IND is basically a request to be able to move to test into humans, okay? So this IND is going to be sort of a living document. If you want to know how much is in there, if you take an 8x10 room, fill it up with legal boxes, probably that would be an estimate of the data that is accumulated. The FDA has to go through all of that, and they have to review that. So basically, if this is approved, it's going to move to the clinical trials. So the first thing we start off with is phase 1. Basically, this is the first human trials of the drug. Typically, we're going to have 20 to 100 subjects, and all of these will be healthy, so they're not going to have the disease. What we're going to do is we're going to give it to to these subjects. We're going to look at pharmacokinetics. We're going to look at pharmacology. We're going to note, are there any, how do these people respond? Are there any adverse side effects or anything like that? And we may look at what's the maximum tolerated dose. So the maximum tolerated dose would be how high can we go up before they have some side effect that they're not going to tolerate it. So this is phase 1. Now, then if that's successful, we now move into phase 2, and there's really two subclassifications of phase 2. So phase 2A, this is really the pilot studies. This is the first time that we're going to give the drug to a person that has the disease. So if we're developing an antidepressant, this is the first time it's going to go into people that have been diagnosed with depression. These studies will help determine the dose range. They're going to determine whether it's efficacious. So we're going to see for the first time, does it seem to work in humans with depression? We're going to get the pharmacodynamics. So that's going to build upon what we had in the animal studies. We're going to be looking for, is there anything different, or is it very similar to what the animal studies? These studies will take a few weeks to months to do, okay? Again, when if we're looking at an antidepressant, keep in mind that we're looking at, something almost a month to 2 months to see if we've got efficacy. The 2B studies, what we're going to do is basically we're going to be looking at again, proof of efficacy to make sure it works. We're going to start doing some controlled trials. Now, when we do controlled trials, we compare to placebo, or what works better is if we're pretty sure that our drug's going to be better than what's on the market, we may use another drug, one of our competitor drugs. So all we have to prove to get approval from the FDA, or the biggest thing we have to prove, is that our drug is better than placebo. Now, with depression studies, placebo can be 40%. Placebo rate can be like 40%, maybe 50%. But in these phase 2 and these phase 2 clinical trials, we're testing both of them to see, does it work? It's the first time it's going into humans that have the disease, and we're trying to get the pharmacokinetics. We may also start looking for drug-drug interactions. We're looking for any safety thing that may flag. So any side effect, are we getting any arrhythmias? Are we getting any changes in, the blood cells, things like that. Then we go to these phase 2 trials. Typically, just a couple more things about it. Typically, this is going to, these phase 2, you may have 20 or so trials in there. You may have fewer than that. But theoretically, you may have, several trials. These are all relatively short-term trials, usually a few weeks, maybe to a few months. And at any of this time, the drug can be pulled. So, for example, if I'm the drug manufacturer and I'm finding out in these phase 2 trials that I'm getting an antidepressant effect, but it's just not real good. It's probably, it's just barely as good as my competitor, or if it's inferior to my competitor, then I'm not going to develop it. I mean, it's going to be hard to market it that my drug is not as good as what's already out there. The other thing is if I have certain if the side effect profile, a lot of times drug companies will come out and they're not able to say their drug is superior in efficacy, but what they try to do is they are trying to basically to identify that their drug is safer, less side effects. Now, one of the things that we find many times, we see a number of drugs that have been released that say that they have less side effects than the existing drugs after it gets into the real world, and we start seeing a lot of people that are, basically been exposed to the drug. We find out that the side effect profile is about the same. Or the other thing that could happen is we may find some significant drug-drug interactions. Another drug that most of my patients that I'm intending to use this drug in use another drug, and the drug-drug interactions are serious. So what we find is these phase 2 clinical trials is the first time we're seeing it in patients with the disease. And if the drug really doesn't show promise that we can market it, then basically the manufacturer may just say, we're pulling it. Because when we look at the cost, it's very, very expensive to develop these drugs. And so to go through the entire development of these drugs can be really expensive. Now, the manufacturer has already got a significant investment in these drugs right now. But we find typically by about phase 1, typically, and definitely by phase 2, over 50% of the drugs that go into the pipeline get pulled. Just simply, they're not found because of the problems with them. The drugs just haven't shown to be, a benefit and worth developing in that way. And the other thing is, if we have some serious concerns in phase 2 clinical trials, the phase 3 clinical trials, which are the large randomized control studies, those are very, very expensive. They're expensive in money, they're expensive in other resources, they're expensive in time. So the phase 3 clinical trials are the big, large clinical trials that you see, released in the news all the time. Typically, they involve placebo and or a comparator drug. The nice thing about it is if my clinical trial comes out and shows my drug is better, then I can advertise that the drug is better. I have data that shows my drug is better than this other competitor. These trials are typically randomized controlled trials, and we call them RCTs, and they are considered the gold standard. Typically, and I say typically, the FDA requires 2 pivotal trials to get approval. So you have to, and it's not uncommon for some of these companies to run, they typically are going to run 2, but they may run 3 or 4, maybe 5. They're not going to run 15 or 20 typically because it's too expensive. Now, some things that may come up in these clinical trials may result in the aspect of let us try to follow along and do some additional trials. And so they may they may set up for some post-marketing studies. Sometimes the FDA may require them, say, we're going to approve the drug, but you're going to have to do some other post-marketing studies, which means these studies will be done after the drug is approved. It may mean track side effects or determine what the true incidence of certain side effects are, or some drug interaction. Interestingly, there's been some papers that have come out that basically have said that even though the FDA required these type of approvals, if you will, or required these post-marketing studies. They approved them with the requirement of these post-marketing studies been done. A large number of those studies were never done. It's sort of like you're telling your parents, if you'll let me borrow the car tonight, I'll wash it, every week for the next 3 months. And, you borrow the car for the night, and then basically it doesn't have it. It doesn't get done. So then when we finish the phase 3 trials, this is when we put in the new drug application. And that's what basically integrates all your preclinical studies, and it integrates also the clinical studies. Now, let me point out something. We're going to go back a couple of slides to the main map we had. All right. So if you look down here, some of these animal testing studies are short-term, but we may be doing like some of these drug tests for carcinogenicity and so forth. They may be concurrently running while we're doing the clinical trials. The FDA may say, everything looks good, but let's keep running those animal studies just see if anything else is going to show up. So some of those long-term studies may actually carry all the way in, sometimes even to after the drug has been marketed. But again, when we get to that NDA, now we've got not only that 8x10 room that's full, we probably have another 8x10 room that's pretty full too. But basically, that new drug application is the integration of the IND plus the clinical trials. Okay? Anybody have any questions with regard to the basic process here? All right. So what you need to know about the FDA approval, all drugs, including over-the-counter drugs, in fact, many of the over-the-counter drugs basically started off as prescription drugs, and most of the over-the-counter drugs are basically, we've had them out as prescription drugs for a while, and then they have been submitted, and usually we find the over-the-counter drugs are typically just a lower dose. So for example, let me pick ibuprofen because I know this. An ibuprofen prescription is, I think, 800 milligrams, okay? Ibuprofen over-the-counter is 200 milligrams. Pseudoephedrine prescription used to be 60 milligrams. Over-the-counter was 30 milligrams, okay? So the FDA is approving all of those drugs. Now, supplements and herbal and homeopathic do not go through this process, okay? And we're going to talk about generic drugs in just a minute because you need to know about those. But even generic drugs have to be FDA approved, okay? So FDA approval, what does that mean? That basically means it's not a guarantee of efficacy and safety over the life of the drug. In other words, as long as the drug is out on the market, what it means is basically that based upon the information provided to the FDA by the drug manufacturer, is the FDA reviewed that, and the FDA basically has said that based upon this information, we feel the drug is safe to use and it's efficacious, okay? The FDA does very little testing on its own. So for example, if I'm a drug manufacturer and I hand them all this information, typically the FDA is not going to go back and start doing some experiments to test it out. They don't have the time or the resources to do that. In fact, the FDA is pretty much stretched with regard to its ability to think about it. It's looking at food, it's looking at drugs, it's looking at all these different things. So when the FDA approves it, the drug is approved based upon the indication. So what condition is it going to be treated that the manufacturer provided data on, and the dosing that was described in the NDA. This is what is all provided it's provided by the manufacturer to the FDA. So what FDA approval means is that the drug has been deemed to be safe and effective for the approved indication. So if it's an antidepressant, it's been deemed to be safe and effective for the treatment of depression. Does it mean, even though it may be effective and people use it for it, does it mean that, for example, the drug is going to be used to be used as an antipsychotic? Okay. It means also with approval that the drug is, I underline this, not likely to cause frequent serious side effects in the intended population for which it's approved. If there are some side effects, the FDA may require certain monitoring, such as what we see with clozapine. Clozapine is a good example of where the FDA requires certain monitoring, okay? So it may require, like, for example, with some of the acne medications, it may require that the person take a pregnancy test and be on an oral contraceptive. So when there are some potential side effects, that's when, basically this comes into play. Now, let's talk about the drug label. And because this is important information that is, this is actually written for the prescriber. The drug information, the package insert, basically is not written for the consumer. Okay, we call that the learned intermediary. Let's see, we have a question here I missed here. How does the FDA ensure fidelity of manufacturer's data? That is a big point. That is, I will tell you, I've served as an expert on behalf of plaintiffs for a number of drugs, a number of compounds, and we have seen where that the drug companies have not provided information or have hidden information from the FDA, and the FDA basically that's why sometimes why drugs are withdrawn from the market. You see several drugs. So let me give you an example of a drug where that occurred. So there was a drug called Baycol. I don't know if you guys remember it. It was a statin. It was used to lower cholesterol. So here's what happened is Baycol got pulled off the market. One of the reasons for that was because that people were developing rhabdomyolysis compared to a lot of the other statins. Okay, do we know that statins can cause rhabdomyolysis? Yes, we do. So the company, when it was doing its clinical trials, they were monitoring CPK. Remember, CPK is the enzyme that we monitor for rhabdomyolysis, creatine phosphokinase. So if somebody starts developing pain in their calves or in their muscles and fatigue and so forth, and they're on a statin, we tell people they need to look at their CPK values. Okay. So what Baycol was doing, or what happened with Baycol, when they were doing their clinical trials, they had their criteria was that if someone's CPK values went up to, and I'm remembering vaguely, it's been many, many years, but basically their CPK values, if their CPK values went up to I think it was 5 times the upper limit of normal, they were pulled out of the trial. Should they have done that? Yes, because that would mean the person was at risk for developing CPK. But what they told the FDA was that in their clinical trials, there were no cases of rhabdomyolysis. They didn't disclose to the FDA in a straightforward manner the fact that they had pulled a lot of people out of the trials because of the CPK values going up. So one of their documents, the person says, well, no wonder you don't have any rhabdo cases in your clinical trials, is as soon as they start developing symptoms, you pull them out. So that was an example of where that when you go back and looked at the data is basically, or that it comes across that the information was there were signals where the drug may be causing rhabdomyolysis, but those were sort of overlooked or not given to the FDA. So we have seen that occurring, and we've seen the FDA sometimes miss. Again, the FDA is I don't think the FDA actually knows exactly how many drugs, including OTCs, are out on the market that they're overseeing it. There's been a statement about that, but that's been an issue there that occurs. So sometimes we've seen safety issues have come up, and the companies have been reluctant to change their label or let the individuals know, let the prescribers know there's some issues. By law, and when I'm talking about law, we're talking about the Code of Federal Regulations. The drug manufacturers are supposed to review their label at least annually to make sure that or to let us know if there's any new or if there's new safety information about their drug. And their drug is supposed to be accurate. If the label is not accurate, then it's considered misbranded, and the FDA can pull it off the market and actually fine the drug companies. Okay. So sometimes manufacturers have downplayed adverse events. So instead of moving them to the warning section, they've kept them buried down in the label. We've seen that happen. You guys remember Fen-Phen? One of the things was that there was pulmonary hypertension, which could be deadly. And what they had was in the label, they had pulmonary hypertension listed under the adverse events, which was way down. And they said there's been 4 cases of pulmonary hypertension. So when you look at a rare disease and you see that Fen-Phen, as it was taking off in the market, you saw that you were seeing a lot more prescriptions that were occurring. What happened is basically, if you're a prescriber, you're saying, well, a lot more people are using it, but the pulmonary hypertension isn't changing, so it must be pretty safe. So in that particular case, what they had was there were 4 cases listed in the label, but there were over 37 cases that weren't listed. And in fact, there had been people in the company that had been told to, instead of coding them when they came in listed as pulmonary hypertension, they were not coded as pulmonary hypertension. They were coded as cardiovascular problem or disease miscellaneous. So we've seen this thing happen. There's several books that have actually been written that talk about things that have been occurring, that has occurred. And so that's a big issue that's there that comes in with several drugs. Okay. So what's happened a few years ago is the FDA reevaluated their labeling. What we found is basically that the label, the old label, if you talk to people, for example, if you pulled up a PDR, everybody complains the label is so tiny, so much information, and people found it very difficult to read. Well, then now we started to have labels where we can pull them up on the computer, which makes it a lot easier. I rarely go to the PDR. And by the way, the PDR, drug companies are not required to put their compound or their drugs in the PDR. In fact, that PDR is put together by drug companies, and it's actually, it's a form of advertising. So a lot of people will give, new physicians, they used to get PDRs gratis and so forth, but a drug company is not required to list their drug in the PDR. It costs them to do so. And so not every drug will be in the PDR. So anyway, the FDA recognized that the drug label as it existed was difficult to read. And so what happened is they initiated a few years ago a new drug label format, which includes sort of the executive summary or the highlights section. And this was sort of an overview it provides an overview of drugs, benefits, and risk. And then it has a content section so the most important information is right there so you can see it very easily. And then it will refer you to where there is a more detailed information. Okay. So let's see. All right. In the highlights section, I'm going to cover this first part of the label, and then we're going to take a break, and you guys have got 4 questions to do. We're going to sort of merge in with your break. So the new highlights section, basically on the new label, it's got a limitation statement, but it gives the product name, it states when it was initially approved in the United States. Then if there's any if it has a black box warning, then the boxed warning will have bullet lists that are the most pertinent things. So it doesn't give the whole entire black box warning. It just gives sort of a highlights of that. We also see it for the first time is it will say any recent major changes. It may tell you that there was a recent label change. It will give the indications and usage, what it's been approved for, and that's a bullet list. It also tells what its pharmacological classification. So, for example, it may say an SSRI, it may say it's a ACE inhibitor. So you're aware, that lets you aware that it fits in with these other drugs. So that gives you a point of reference. It'll give you the dosage and administration. Contraindications, these are all, it doesn't mention any relative contraindications. These are straight contraindications. And then it gives you the warnings and precautions, which are basically, it's an abbreviated summary of what is considered the most clinically significant adverse reactions and what to do. Okay. It also, if you need to monitor, it will give you the monitoring parameters. It may tell you you need to monitor, do CBCs or liver function tests. Most common adverse reactions and the percentage of occurrence is now listed in that highlight section. Tells you how to report. We're going to go on about this reporting before we end today. And then it will tell you if there is any clinical significant interactions. And not only are they, if there's an interaction, but it'll tell you the nature of the reaction, whether it's an allergic reaction or whatever. So that is all in the highlights section. Gives information about use in specific populations, geriatric, pediatric, so forth. And then it also gives you some information about patient counseling. Now this new highlight section is the first page, and it's very, concise, but basically this is what one looks like. This is from the FDA. So you see up here, there's the limitation. These highlights do not include all of the information. So see the full prescribing information, which is they're using a makeup drug called Imidacon. So here it is. Here's Imidacon. It tells what the drug is. That's a made up thing. That's capsules. It's approved in the United States in 2000. Here's a black box warning. So you see that it's just bullet points of what's occurring. Here there's changes in, for example, in February of 2000, whatever, there was indications and usages. They included coronary stenting. And then the 1.2 is the part of the label when you look down into it that will give that specific information. It also says there was changes regarding the dosage and administration, and that's in section 2.2, and that occurred in February of 2000X. Here's the indications and usage, the dosage and administration here. This is the dosage form, so this comes in 50 milligram capsules. Here's the contraindications, the warnings and precautions. Again, very abbreviated list, but here's the monitoring. Monitor for hematological adverse reactions every 2 weeks through the 3rd month of treatment. The most common adverse reactions, incidence greater than 2%, so diarrhea, so forth. Again, all of these in parentheses represent the point in the, when you go further down in the label where you should go to. Here's how to report suspect adverse reactions, which is linked into the MedWatch, which we're going to talk about a little bit later. And here's the drug interactions and specific populations. Tells when it was revised, when the label was revised down here. Patient counseling was revised at this time. So this is the new, which gives you the very upfront, so you don't have to look through all of that, but it then refers you to other parts of the label for more information. And if you want some additional information, this is actually the FDA website you can go to. So remember, the FDA approval is not a lifetime guarantee for safety and efficacy of the drug. We've had drugs pulled off the market. We've had drugs that the label has been changed because of new information. So what we find is that as the drug leaves and starts being used by more and more people, what we start seeing is basically we're going to see drug risk increase because we're going to see different people with different conditions and so forth are going to use it, which is going to uncover some other side effects and things like that. All right. So let's take our break. And Marissa, if you want to go ahead and set up those 4 questions. So let's come back at 5 after the hour. So that'll give you time to do the 4 questions, and then we're going to pick up on this other testing and limitations. Okay, guys, let's go ahead and get back. And what we're going to, one things I want to make a point with is that when we're doing these clinical tests for new drug improvement, a big concern is think about this. When we look at the number of patients that's involved here, going to these trials here, we're looking at phase 1 is 20 to 100. Phase 2, we're maybe looking at 20, I didn't tell the numbers, is maybe 100 to 200, maybe something like that. Phase 3, maybe 1 to 5,000. So when you're looking at these, basically two things that you're happening. First is you've got a limited number of patients. Okay, I mean, think of it. If we had 6 or 10,000 patients, that's a big difference between when it goes, a drug may be hundreds of thousands of patients. And when we start getting 100,000 patients, we're having some issues that are coming into play. That we're not picking up this full breadth, and especially with rare side effects, we're not going to pick it up. So we have a limited number of patients. These are not real world, everyday patients. The other thing is that the issue comes into play is that with these limited number of patients, we're choosing those patients. We have exclusions, inclusion and inclusionary criteria, which basically means that we're hand selecting these patients, and we're not basically, it's not going to be a patient with typically with multiple comorbidities. So that's one of the big limitations with clinical testing. One, rare side effects is not going to be picked up in the normal clinical trials. Two is that we've carefully selected these patients. We're closely monitoring them. So the other thing is what we're looking at is drug companies, we're really looking at, are we looking at efficacy or safety? So the issue is we look at both, but a lot of the clinical trials are looking at more of efficacy versus safety. So that's one of the limitations. There's several limitations to these clinical trials, which means once we get out into the real world, we a lot of times see new side effects or some side effects which we thought were rare, maybe not as rare as we thought. Now, let's go to a big issue, because this is what most of you are going to be prescribing, generics, okay? Generics emerged because basically it was considered, when they looked at the cost of healthcare, one of the things was healthcare was very expensive, and a major component of healthcare was prescription medications, okay? So generics, the FDA looked, and in 2002, the FDA actually did some studies, and they estimated that by using generics, they could save approximately $57 billion per year. They further estimated that for each 1% increase in generic drug use would save about $1.32 billion per year. So the FDA saw, by going to generics, now, first of all, let me tell you, back in the 80s, generic drugs were available, but they had to go through the same process. So if a generic company decided to put out a new to put out a generic tricyclic antidepressant, they had to do the same testing. They had to repeat all of that testing that was done for the name brand product. So the FDA came back, if we can make the approval process smaller or less cumbersome, it could cause drugs to be a lot cheaper. So basically, what I was saying, prior to 1984, generic drugs had to do all of the same testing we talked about. There was very few, if you think about it, in the early 80s and before, very few generic drugs were prescribed. Everybody took name brand. So what we saw is that in 1984, they passed what is called the Hatch-Waxman Act. And basically, this was, the FDA said that we can have an abbreviated approval process. So what they came up with is the ANDA stands for Abbreviated New Drug Application. And what the FDA said is that with this act, basically is that if you had a generic drug that all you had to demonstrate was bioequivalence, and you didn't have to go through all the other testing. Their rationale was that the testing basically was already done, so why repeat it? This act also allowed generic drug manufacturers to start looking for FDA approval and do these bioequivalent studies before the patent run out. The name brand would have the patent. So, and it also provided, so if there was some disputes between the brand and generic firm, it provided a process for basically resolving that. But we're focusing on really this abbreviated new process. So the generic process, basically, you have the applicant, which is a generic company. They have to put in an abbreviated new drug application. So what they have to basically do is they have to demonstrate they can make it. So they have to request that the FDA show or review their properties and inspect their properties and make sure that they are able to do it. If it was, they have to demonstrate that the chemistry and everything is the same. The label has to be, they refer to labeling, the generic company has to, the label on the medication has to mirror the brand name, and they had to demonstrate bioequivalence. And the bioequivalence was really the big testing that they had to look at. So if we look at that, the branded drug takes, so figure to get the, or soonest to get it on the market, this is 3, 4, 6, 9, 10 years. 10 years minimal to get a drug on the market. With the generic drug, basically what they're saying is all of this has been done by the brand drug, so we don't have to do that anymore. So basically, we take the efficacy and safety that was proven by the brand name, and then they do formulation and bioavailability studies. So they have to basically show that they can make the drug and show that it is bioequivalent by doing these bioavailability studies. And then they figure putting the ANDA together and getting it approved is about 2 years. So whereas this takes a minimum of 10 years, you're looking at 2 years. So because you're not having to repeat all of this information down here, this they're taking from the brand name. And so what generic companies do is basically they move in when the patent, most patents in the United States, there were some for 14 years, others, most of them now are 20 years. So basically when the patent runs out, generic drug companies can step in. That's why that branded drug companies try to get the drug to the market as quick as possible so they can make their money back on it before it goes to, before the patent runs out, which then opens the door for the generic companies. So the FDA requires a generic drug to contain the identical amounts of the same active drug as the brand. It has to be given by the same route of administration, typically it's oral, has to have the same indications, has to have the same dosage form, okay? So those are requirements. When we look at, this is jumping around here, the ratio of active to inactive ingredients must be the same. So anytime you get a drug, what you have is, let's take, like for example, Zoloft. So we have the Zoloft in the product, and then we have other things like fillers and dyes and stuff like that. So the percentage or the ratio of those inactive ingredients have to be the same in the generic. They don't necessarily have, the inactive ingredients don't necessarily have to be exactly the same. The active component has to be there, and they have to demonstrate it's bioequivalent, okay? And I'm going to go through what bioequivalence is in just a moment. So with bioequivalent, I mean, the other thing is they typically the brand drug becomes what is referred to as the reference listed drug, which means that is the standard that all generics have to go to. So let's say Motrin, let's take ibuprofen. Motrin is the RLD, and all ibuprofen products, if it's CVS's product, if it is Walmart's product, if it's Publix, all of those have to make sure that they're comparing all to the Motrin, which is considered the RLD. The FDA keeps what is called the Orange Book, which lists the reference listed product for every drug. That's to make sure that one standard, that the active ingredient, all the generics are compared to, rather than having different standards. All of the products, so if we're talking about Motrin, all of those Motrin, all of those ibuprofen products have to be bioequivalent to the Motrin, okay? And that is to reduce the variation, so there's no significant variations among the generic products. So that's the theory with this. The drug label is going to, even though it says it's going, all of the pertinent information is supposed to be there, but what's going to differ is we're going to have, for example, equate Motrin versus Motrin. Now, sometimes there may be some patent or exclusivity issues that are there. The label can delete those. The excipients and some of the inactive products, they can differ somewhat in the pharmacokinetics and how it's supplied. So when I say how it's supplied, basically it could be that maybe Equate comes out and it has a bottle of 250 200 milligram capsules, whereas Motrin is in bottles of 100. So the ANDA holder, the generic company, is if they feel that there's new safety information, because sometimes the brand name has quit making it because it's just, there's all these generics, they're not going to do it. So the ANDA holder basically is supposed to notify the FDA if they come across any new safety information. This is coming up, this is under a thing legally that was called preemption. And then the FDA then can decide whether the labeling needs to be changed, okay? Personally, I think the way it was written before, because I was involved in a Supreme Court case that was dealt with this, is personally the way the regs were written, they said that if an ANDA holder saw differences, they could initiate a label change. But now legally they're saying that they can't. Kirsten, so what happens is that it's when you're talking about rebranding, is the patent may be get up, but we do see a lot of drug companies that will make the generic drug. So they had the whatchamacallit, the original branded product. We do see a lot of the drug companies, it's not really protecting the patent, but it's basically they're staying in with the market. So the patent basically is expired, but they since they're making it already, they will keep it going that way. So the big question here with generics is they have to be bioequivalent. So what does that mean? So this means that the in vivo, so this has to be tested in vivo, so in humans, the in vivo bioavailability of the generic cannot differ significantly from the RLD, okay? Now here's the big issue. This bioequivalent studies, and this is where people have some concerns. The bioequivalent studies is done in 24 to 36 healthy adult subjects. They get a single oral dose. And if the parameters match, they're good to go. The concerns are that one is a lot of people would prefer the bioequivalence be determined in patients that have the disease, because some processes may be changed during the disease and that could affect the bioequivalence. The other thing is you're doing a single oral dose, and many of these people are getting dosed chronically, and it's a small number. You're only looking at 24 to 36 people. That does not take a lot of time or money to do. It's a significant amount, but again, compared to a randomized controlled trial, it's significantly lower. So that's what bioequivalence. Now, what do they measure? Well, there's two parameters that are measured when they do these bioequivalent study. One is called area under the curve, which we talked about earlier today, and you can see the gray area. This is the distribution of the area under the curve is in gray. They calculate that. And the other thing is Cmax, so the highest concentration after a single dose. So what the bioequivalence, what a generic company has to demonstrate, they measure those two parameters. And the way that it's phrased is that the confidence intervals, the 90% confidence intervals for the area under the curve and the Cmax must fall within 80 to 125% of the branded drug. So there's some variation that's there, okay? And the problem with that is the assumption is that if those two parameters match or they fall within those specs, that the drugs act equivalently. And people have argued against that, okay? So first of all, this 20% to plus or minus this minus 20 to plus 25% range, which is this 90%, the 80 to 125% of the branded drug, that variation falls in there. That was really a regulatory decision. That was not based necessarily on science. So we're not quite sure where exactly or how exactly they came up with that. Their statement is that if the drugs are bioequivalent, that most drugs with the same active ingredient should not have any clinically significant differences in blood levels. That is what the theory is, okay? And in most cases, that's what holds. But the question became, again, because of the limitation in testing that's done, there is a concern. The FDA, to bolster their opinion, is they reviewed generic drugs versus the brand in 1987. They also did it in 1997. And they said of the drugs they tested, the area under the curve only differed by about 3.5% among the generics, and the Cmax was only between 3.5 to 4.3%. So the FDA basically said this supports the concept of safety and efficacy of the generics. And it also supports that it's okay to switch between the brand and a generic or between different generics. That's the FDA's view there. And in fact, here's their graph. And if you see, basically the reference brand is in yellow and the test generic is in red. But people was like, looking at this, I mean, we don't really know, what's there, but we see a little bit of deviation here. We see a little bit of deviation in here. And could that be significant? So that's one of the things that people have argued. Don't worry about this, but we do, sometimes they will say that they're, the FDA calls them bioequivalent A, which means that they're definitely bioequivalent to the brand. If they're B, that means that the bioequivalency has not been determined. That's usually some of the much older drugs. But these are just some other delineations that you may hear of. So pretty much only the A-rated drugs, which is most of what we have as generics, are considered to be interchangeable with their brand name. But here's the thing. A lot of people says, look, bioequivalence and therapeutic equivalence are two different concepts. Therapeutic equivalence basically says that the drugs contain the identical amount of active ingredient in the same dosage form. It meets the equivalent standards for strength, purity, and identity. It's safe and effective, and it has an adequate label. And it's basically, the other thing is the manufacturer has to meet good manufacturing practices guidelines. And here's where the debate comes. Is bioequivalence equivalent to therapeutic equivalence? Okay, theoretically they are. But what we find is, so the bioequivalence, which is tested, that implies that the generic and brand basically reach blood levels at comparable concentrations over a period of time. And this is dependent on that the pharmacokinetic parameters, the AUC and the Cmax, are representative of what's happening. Therapeutic equivalence says, the difference here is therapeutic equivalence basically says they produce an equal therapeutic effect. And that is dependent on not only pharmacokinetics, but it's also dependent on pharmacodynamics. So bioequivalence is dependent on pharmacokinetic parameters and implies that pharmacodynamics are equal. Therapeutic equivalence is dependent on both pharmacokinetics and pharmacodynamics, but there is no regulation that is required to demonstrate therapeutic equivalence. So both of the parameters, whether it's bioequivalence or therapeutics, assume that the brand and the generic reach blood concentrations that are comparable. Okay, the therapeutic equivalence assumes that they have the same pharmacodynamic actions. So bioequivalence is primarily pharmacokinetics. Therapeutic is pharmacodynamics and pharmacokinetics. The FDA doesn't check therapeutic equivalence. It doesn't. The drug companies don't test therapeutic equivalence. So the FDA assumes that if they're bioequivalent, they're therapeutic equivalent. That is the assumption. Here's where the concern is. There are certain drugs that are considered narrow therapeutic index drugs. We talked a little bit about this yesterday. These drugs, what it means is that the dose that we can safely use the drug is very close to the dose that causes side effects and sometimes serious side effects. So therapeutic equivalence is really of concern with drugs that have a narrow therapeutic index, because a small change in the blood concentration can make large pharmacodynamic changes. So we can go from therapeutic to serious side effects. This is where we have real concerns with regard to these drugs. Okay. Now, what is a narrow therapeutic index? If you go to the Code of Federal Regulations, 21 CFR 320.33 subsection C, the FDA's criteria is that there's less than a twofold difference in the median lethal dose and the median effective dose, or there's less than a twofold difference in the minimum toxic concentration and the minimum effective blood concentration. And the safe and effective use of the product requires careful titration and monitoring. This last thing here is probably the thing that we focus on, is a lot of these drugs that require very careful monitoring probably fall into this category. According to the FDA, they have identified 5 drugs that fall into this category: digoxin, lithium, I've got it in red because that's one you're going to prescribe; phenytoin, which is used for epilepsy and seizures; theophylline, which is used for treatment of pulmonary disease; and then warfarin, which is used as an anticoagulant. But other organizations have identified what they consider as very narrow therapeutic index drugs. Cardiac electrophysiologists say antiarrhythmic drugs are like this, because it doesn't take a big change. A lot of antiarrhythmic drugs can very easily become proarrhythmics. So a lot of cardiologists, electrophysiologists that are treating arrhythmias do not want generic drugs. They want the name brand. Epileptologists include anticonvulsants. This is one you should be aware of because you will prescribe anticonvulsants. Some of the mood stabilizers are anticonvulsants, Tegretol and so forth. The reason the epileptologists are concerned is if somebody has a seizure because a drug is not bioequivalent, basically that can mean, put that person at high risk, can prevent them from driving, working, and stuff like that. And then also, the Kidney Foundation has included immunosuppressants, because if there's a slight variation that somebody that's got a renal transplant, kidney transplant, basically that could cause them to reject the kidney. So there's some debate about what is really the narrow therapeutic index drug. Okay. What in your line of things, we see a lot of people that want brand name levothyroxine because they think that slight variations that may occur with generics is a problem. Now, one of the things that you need to be aware of is that years ago, we would have usually the name brand and one generic. Now we have multiple generics, so we may have more variation. So you may go in and take a generic from McKesson, and then you go to another pharmacy, or your pharmacy gets a better, 2 or 3 months from now, gets a better price from another generic drug company. So there's more concerns with regard to more variation. So even though they're all compared to the reference listed drug, what we may see is one generic may be on one side of that, the other one may be on the other side, so there may be a wider variation that's occurring there. Things that can alter bioequivalence, we've talked about these: age-related changes in pharmacokinetics, comorbid diseases, multiple medications with multiple drugs. We have some other things that come into play here. Again, these bioequivalent studies are done in normal, healthy adults. They're not done involving people with comorbid diseases or people that are taking other medications. Drug-drug interactions that occur in the real-world patient, they're not going to be picked up there. Look at this last point. This is something you need to be aware of. What about the changes in the dyes or the excipients? So, for example, if you've got someone who is lactose intolerant and is taking a generic that has lactose in it or has gluten in it, and they're gluten, have a problem with gluten, that could upset their stomach, could change the pharmacokinetics. So that could affect the drug absorption and affect the overall effect. So So Jason, the thing is that the variation is that when you go to generics, because you have other drugs, I mean, you're making those drugs, just the normal manufacturer is going to produce some degree of variation. So theoretically, they have the active amount in the same amount of that generic, but how it's manufactured. We've seen, for example, just some manufacturing plants may change sometimes some of the pharmacokinetics, and it may deal with the excipients, it may deal with the manufacturing process and how they put it together. So that can occur in that particular scenario. So the FDA puts out, are generic drugs safe? They've got all this advertising campaign, and they do go through all of this testing, so they are much safer than other things, but they still can vary, and that's an important thing. Now, the last thing that I'm going to cover is really drug safety, and then when I finish these next few slides, we're going to have your last 4 questions and then your post-test. So I'm going to try to finish these up in the next 5 minutes or so. So once a drug is out, how do we monitor its safety? It's through a process called pharmacovigilance. Pharmacovigilance, what it does is it collects, it monitors, it assesses, and evaluates adverse events. They get the data from healthcare providers. We have a number of sites that collect this data. The FDA has its own collection of adverse events. Data comes from, if you have an adverse event, you could turn it in, your doctor could turn it in, drug rep could turn it in, lawyers can turn it in. So it's collected. And what we're trying to do is, by collecting this, trying to determine what is called a safety signal. Are there any things that suggest that there may be an increase in an adverse event or the emergence of a new adverse event? So if we can pick that up early, then we can possibly change the label or notify people to avoid doing certain things. And by doing that, we're going to prevent patients from being exposed to unnecessary risk. So what it's really designed to do is to try to pick up new, rare, and serious adverse events, which may not have been picked up in the clinical trials. So this is going to be important. The MedWatch program was established in '93 by the FDA. It was to simplify the reporting process of adverse events. The FDA clarified what they needed. They also, it's coupled in with to enhance the awareness of these serious side effects, so that you as a healthcare provider and even as a patient know about this. So the MedWatch program does not require that someone has to demonstrate that for sure that the drug has caused the adverse event. Okay. So when you turn in a adverse event, you don't have to prove that it is caused, that's the causation. The minimal information you need is, we need a patient, we need a drug, and we need an adverse event. Now, how that patient's identified, you can put their name, you can put their initials. It may be a 21-year-old experienced a rash. It could be a female experienced a rash. While taking, ibuprofen, or while taking Zoloft. So that's the minimal information. And they want the 4th thing is really the reporter, because they will contact you to say, ask you and get more information about it. But the better the information, the better. So the more information you can provide, the better off, because it allows them to analyze it. Now, this can be reported, and they've simplified the process. You can call a 1-800 number. There is a FDA 3500 form, which you can mail in. You can fax it in, or you can even go onto the internet. And the form this is called a MedWatch form. Notice it says for the voluntary reporting. It's not mandated that, for example, if you were the prescriber, you do not have to report it, although we greatly encourage people to do it. But you see at the top here, they give us the patient information. So we just need to have some identifier. If it's a 21-year-old female, if it's a 8-year-old male, if it's just an 8-year-old, as much information as we can get here. The adverse event, or if it's a product problem. So for example, if it was a medical device, what happened, if we know that. Sometimes we don't know, but we may know sometimes whether the person had a life-threatening event, or if they died, or they were hospitalized, but sometimes we don't know what's occurring. When did the event occur? what happened, any laboratory data, if we can get that, any other relevant history. And then we call it the suspect medication. It's not called causation. So if we think it was, for example, we just started them on Zoloft and they started a rash, then we would put that, what dose if we had the dose, the lot number and things if we had it. And any of this information, we may not have all of this information, but if we do, we include it. And then they put, basically who did it. If it is a health professional, it is generally regarded by the FDA as being more reliable. That's not always the case, but sometimes because we've seen lawyers sometimes that have more medical records that are presented than the healthcare professional. The patient can do it. Patient's mother, father could do it. So they collect all of this, and it is a voluntary reporting. So what happens with these MedWatch forms if we see a signal or something arise? One can be, there can be warnings go out. For example, when we started seeing the suicidality of the antidepressant drugs, warnings went out. They can send Dear Doctor letters, and these can either be Dear Doctor or Dear Healthcare Provider or Dear Pharmacist. So these go out from the FDA and says, we've determined that there is a potential drug interaction that's occurring, and this is what we suggest doing. And in some cases, the drug may be withdrawn. So that's what we do. When you look at the percentage of adverse events that are actually reported, it's usually probably only 1, at best 10% of the adverse events that are reported to the FDA MedWatch system. Now, sometimes these reports go to the drug company. The drug companies are required to forward those to the FDA. Some people will submit them to the drug company. Sometimes it's the adverse event is the drug didn't work. So if somebody writes in and says, I was prescribed this, it didn't work, I want my money back. That is considered an adverse event, that the drug didn't work. So from these slides, basically what I want you, from this last group of slides, know the drugs you prescribe, know the label, make sure you stay up on top of it. Keep in mind that this drug safety evolves. So what may have been look like a good drug to begin with may develop some side effects and may be pulled out. And keep current. Know the drug label. Here's what I want you to do is MedWatch. MedWatch, if you go to the FDA side, if you go to this website or just go to MedWatch, basically it will, I don't know if any of y'all belong to MedWatch or subscribe to MedWatch. Excuse me. What happens is that you subscribe and they will send you updates. You're not going to have your email box filled up with updates, but if there is a major recall, if there is this includes supplements and things like that. If there's a problem that comes up, they will send you a notification. Every so often they will send here's a list of drugs where the label has been changed, and it will list the different drugs and tell you specifically what part of the label has been changed. So you can look down through the list and see if there's any drugs that your patients are basically or any drugs that you're using, and you could look and see if there is an issue there. When you look at that, so that's one of the best ways to keep you involved and keep you informed. I'm clicking through because I went to the end of the slides. But a couple other points just in finishing is the off-label prescribing, we can't get around it. But realize that when you go off-label, you're taking on more liability. So it's important that you have a good rationalization to do that. Thank you, Kirsten. But make sure that you may need to monitor a little bit more. Don't become complacent. New drugs aren't always better, and old drugs are not always safer. So be aware. And the other thing is also critically assess all drug information. And I've got including DTC, that's direct to consumer advertising. Drug companies there's only 2 countries in the world that allow direct to consumer advertising, New Zealand and us. A lot of countries forbid it because it creates problems. Don't be pressured by direct to consumer advertising to prescribe a drug that you may not feel is appropriate. And then participate in the MedWatch. Fill in if you have a patient that has an adverse event. It may seem like a minor adverse event, But if we suddenly see a increase in the number of these minor adverse events, it could be a safety problem. So that's the things that I want you guys to think about. Okay. Now, the last thing is, and I went a little bit longer than I was, there is 4 more questions and then the post-test. So if you guys will take that, then we're done. So if you have any questions, some of this stuff we're going to revisit as we go through certain drugs about some of these things, and I will bring up issues that may be associated with labeling and things like that as we get to some of these other drugs. So anybody have any questions? Okay, I'm going to try to have the test to Marissa, the exam for the weekend to Marissa before Wednesday, so it should be available. And you've got the post-test and the 4 questions left from the second part of this. And did you get all the questions? Have we given all those questions, Marissa? So if all 8 questions have been done for this afternoon, then there's no more questions. There's just the post-exam. So I wasn't paying attention to if they got the 4 questions. So if that's the case, there's just a post-exam. Okay. All right, Marissa just noted that the post-test will be open till tomorrow at 9:15 a.m. And the post-test, Marissa, if y'all will post the answers to that and the other questions that you had today, that would be great. And if any of you have any questions about that, just email me. All right. Thank you. Oh, there will, yes, you will get an in-between week assignments. That's a requirement unless that changes. So I will try to have that up on Wednesday, and it'll be due, I think it's Sunday, but I will put that in when we post it. We'll tell you when it's going to be due. So, Eddie, we're going to try to have I'll try to have the pre-test up, or the in-between assignment up sometime a little bit earlier than Friday. It'll be a very short, it may be a quick paper or a little video for you guys to watch in 1 or 2 questions. So I think it stays up through, I think it's up through Sunday night, and then I put in the attendance, that if you've taken the test, I just simply put in you've done the attendance as through attendance. I think I submit that on Sunday night. Okay. So I'll double check, and we'll try to put that in there. Please have done by such and such a day, so that, again, I think it's Sunday, but sometimes in the past it's been questionable whether it's Saturday or Sunday. So we'll check on that. But again, it's not going to be a lot for you to do. Short paper or a short little video or something for you to watch, and just 2 or 3 questions on it. Okay. So it shouldn't take you a lot of time. With that, I'm going to leave this. I'm going to sign off, and Marissa, just send me the attendance and I'll note it. And you guys have a great week. Talk to you later.